moving around in ER is too much of adrenaline, I must say. But this case was one such that I would like to clearly discuss with all of you. And I'm thankful to Dr. Vikas Burney and California Research Institute for allowing me to do so. And this typically started with a 33-year-old female who was rushed into my emergency department, the place where I was working, and she constantly complained of pain in her belly. Well, that looks like this is a pretty common finding in people coming to ER, throwing up, pain abdomen, but this was something that turned out to be totally different for me. So she also complained of 3 to 4 episodes of vomiting, but denied any fever or loose stools or having had anything outside. Also, she refused or refrained from giving any history of alcohol abuse or using painkillers, Motrin, Aleve, or any analgesic use in the recent past. And also, during the detailed history which I took from her, she denied having any bleeding per rectum or throwing up any blood whatsoever. Now, the vomiting which she had was pretty green in color, and that was clearly bilious. And she denied any history of constipation as well. So, as a normal ER intern, I just examined her, and on examination, the findings revealed that her abdomen was pretty distended and it was tense. The bowel sounds were high pitched, and there was no guarding or rigidity at that point. Also, there was not in no presence of any. Also, there was absence of any tenderness when I examined her. She was pretty hemodynamically stable when she presented. So, as of now, what we did was just run on a quick pregnancy test. That was a urine pregnancy evaluation UPT test, and that turned out to be negative because that's usually better that you rule out ectopic pregnancies for any acute abdomen case presenting to your emergency department. So we did that, and that turned out to be negative. And then, as a normal curriculum, we did do some tests like a complete blood exam. But before that, the first important thing you do for any person who's coming with acute pain abdomen is acute abdomen X-ray series. And to our shock, that came back that there was multiple step ladder pattern and air fluid levels, distended loops of small bowel. And we also did a gastrograph in contrast, and that failed to pass to the colon. And we also noted that the radiologist reported that the valvular conniventors were very well appreciated in this film. That was a finding that could be neglected, but in a simple term, I would say that there was findings that were typically suggestive of small bowel obstruction. Now, this is not new for anybody who's working in emergency department. It could happen for anybody who's having any mass, or it can happen from Meckel's diverticulum. So we did do a CT scan, and that revealed that she was having a mass that was causing these small bowel obstructions. So the small bowel obstruction was due to a mass that typically precipitated into susception, and she was just started on nil per oral and IV fluids, NG suctioning, Foley catheterization, input-output charting as a normal small bowel obstruction case, and then plenty of hydration. But she failed to improve with the treatment we started with, and she started becoming hemodynamically unstable. This could also be an indicator that she might have gone into perforation, because usually when person becomes hemodynamically unstable, or the blood pressure starts to fall, or she is not tolerating with the current treatment, and her labs are showing worsening of neutrophil and all the markers of inflammation, you typically think more in terms of perforation. Instead, so what we did was we rushed her immediately to the OR, and then she was evaluated. Under the exploratory laparotomy, which was done on her, the surgeon found that it was obstruction that was due to a mass, and that was reduced. It was basically an intussusception. From the lead point for that intussusception was a mass, and that was successfully resected, and the mass was sent to the pathology department for further evaluation. So till now, we were very satisfied that our treatment did help the patient and she was doing well. But we started looking at the other cases, and then the biopsy report comes back from the pathology mass, or the mass which was sent to the pathology department, and then it revealed that the mass which was in fact precipitating the intussusception was nothing but a carcinoid tumor. And it was important for us at that point to ascertain whether this was invasive carcinoid or it was contained to that particular area. And it did show that it was invading into the muscularis layer, reaching the subserosal fat tissue on the biopsy, but it did not penetrate the serosa. So the excised margin from that area was pretty much free of any cells, and the lymph nodes, which were identified to be enlarged on the CAT scan, also revealed to be negative from any sort of malignant cells. But there was presence of some multifocal hemorrhagic necrosis, some edema, some vascular congestion near the mesentery from where we excised that particular mass that precipitated intussusception. So this was pretty much the case that presented to us, and so we thought of discussing about carcinoid tumor. And this is a pretty rare finding. It's a slow growing tumor. It usually does not produce a lot of symptoms to be identified very quickly, and so was that in this case. So this is a tumor that arises from neuroendocrine cells, and these cells typically secrete a lot of stuff, and that includes peptides, neuroamines. It could also include other substances which typically produce symptoms, not in everybody, but in almost 1/3 of cases. So those humoral factors that are produced from the carcinoids include histamine, kallikrein, prostaglandins, tachykinins. These are responsible for producing the episodic symptoms of flushing, wheezing, diarrhea, the typical triad, which we did not find in this case. But it can also progress to itching, hypotension, tachycardia, sudden bronchoconstriction. These are acute findings. If the carcinoid tumor was present for a longer duration in the body, long-term complications like fibrosis of the mesentery, retroperitoneal areas can also become fibrosed, and patient can also suffer from carcinoid heart disease, which typically affects the right-sided heart and right-sided valves of the heart. Now, the symptoms which are present also depend upon the site of the tumor, the size of the tumor, the metastasis present, and the metabolites which are secreted, whether they are able to bypass the hepatic metabolism, or they are entering into the systemic circulation, or they are getting degraded or not getting degraded. So the site of this carcinoid tumor typically is usually present in gastrointestinal tract, and most of these are found in small intestine. And so in this case, it was a small intestinal obstruction due to the mass that was nothing but carcinoid. But other than that, the other places which are also capable of showing carcinoid tumors include the bronchus, the endobronchial carcinoids, and rectum and other areas as well. Those are going to present with the findings that are suggestive of that particular area. So if it is presenting in the endobronchial region, it can present with the characteristic wheeze, flush, and other mentioned symptoms. And if it is presenting in the rectum or any other area of the gastrointestinal tract, typically it is in the terminal ileum, but can also be in other areas. In the appendiceal carcinoids, they can present with acute abdomen due to sudden obstruction of the appendiceal lumen that can cause appendicitis-like features, and then when you resect it, you might also find a mass. Now, histopathologically, how can you identify the cells which are giving rise to these tumors? These are basically enterochromaffin cells. They stain pretty good with potassium chromate dye. And also you can assess for the number of mitotic figures and also look for a Ki67 index. These are typically done by a pathologist. But the gross classification for carcinoid tumors given by the WHO. This is going to be based again on the pathology findings, whether the cells are differentiated, well differentiated, intermediately differentiated, or poorly differentiated, or from the site of origin, whether they're coming from the foregut origin, from the midgut origin, or the hindgut, if they're from the rectum or other areas. But there are other gastrointestinal neuroendocrine tumors that arise from secondary etiologies. So most of the times carcinoids are sporadic, and they are thought to arise from idiopathic reasons, but sometimes they can also arise from long-standing gastritis, atrophic gastritis, history of pernicious anemia, or any states where gastrin levels in the serum are high. That can also be secondary to chronic proton pump inhibitor usage. And these carcinoids are usually going to be hidden, and it is usually found with atypical symptoms and findings, unless until a very classic feature or triad of wheeze, flushing, and diarrhea is given. The biomarkers you can immediately send for such cases includes the urinary 5-hydroxy-indolacetic acid, and that's what we also did. Blood serotonin levels, serum gastrin levels, chromogranin concentration, and other scans that are very costly as well: pentriotide scan, octreotide scan, gallium scans, and contrast CT for evaluation of distant metastasis, MRI, and PET. There are other modalities to diagnose it as well. So these are most of the times the size of the tumor is going to determine the presentation, and mechanical effects of small bowel obstruction, intussusception, causing pain abdomen happens only when the size of the tumor is large. And this can also cause kinking of the mesentery, and also induce a desmoplastic response in the mesentery as well. Atypical carcinoids have a very different presentation. They are usually non-secretory. These come in the rectum or hindgut areas. They can present with cecal masses that can be easily confused with colonic carcinomas and present with altered habits in bowel, or can also cause large bowel obstruction. This should be kept in mind when you're looking for any case that you're thinking might be colorectal cancer. Obviously, colonoscopic biopsies will help you identify that. But besides that, carcinoids are also notorious to cause the same. So this case was basically evaluated for underlying cause of small bowel obstruction, and to our surprise, the biopsy findings came back. The excised area of intussusception, because it was gone into necrosis or the vascular supply was cut off, and that was sent to the pathology. We were lucky enough to find out that the cells in the mass which was present in that area and was acting as a lead point was nothing but a carcinoid tumor, even though it was considered to be benign in this patient and was not invasive in nature or showed no features of metastasis on the follow-up CAT scan. We were still thankful that we managed this patient well. And I also just thought that this could be a great case for anybody who's working in ER and looking for cases who are rushed in every day for acute abdomen. Thank you.